snow on Hill?
I'm kind of tired of the snow.
Yeah.
Yeah, but the last couple of days, I decided to do home office because I don't have winter tires.
Yeah.
And the other day, we couldn't go. Well, we could go, but we had some trouble going up the hill.
Yeah. That'd be
Because it
smart.
was very slippery. So
Yeah. It's crazy. I don't think I've seen this much snow in 2 days, like
Yeah.
ever.
mhm,
I probably have at least 2 feet at my house
really,
in just 2 days, which is like heard of.
yeah. Today is the last day,
Yeah.
supposedly. Right?
Yeah, it'll probably all melt off. Let's see. Yeah, crazy, huh?
Oh, we haven't all gotten caught up in a while without a
Yeah.
guest speaker, so
Yeah.
I think the first thing I want to do is make sure that we all kind of go around the room. Hafsa, it's in the middle of the night for you. I think. I'm sorry, you don't have to be on these meetings when it's in the middle of the night for you.
Where are
No,
you?
that's just
Yeah.
really fine.
Lahore.
I didn't know you're in Pakistan right now.
I
Yeah.
am. Yeah.
But I thought maybe you could start by introducing yourself and to the team, and we can all just kind of go around really quickly and get to know each other before we kind of talk about what's been going on for projects. So
Okay.
Hafsa, why don't you go ahead?
All right. So as you know, my name is Hafsa. I did the MPH with emphasis in global health from the U. And before start working here, I was working at the U with Utah Children's Project as study coordinator.
I'm sorry, which project?
Utah Children's Project,
Okay.
UCP ECHO.
Can you talk a little bit about that? Because I don't remember about that now.
So it was basically, it's a project with the DFPM department, and we were working to see the environmental, like how the things affect children health, basically all the environmental factors. And I was the lead there, and there was also an environmental part of that where we were putting sensors in families' homes to see how the air quality affects children health too, especially with asthma and all those. So yeah.
Fantastic, thank you very much. Tim, do you want to say hello?
Hello, everyone. My name is Kimberly. I am a research manager for the Department of Surgery, and I'm now helping support the team for the Center of Global Surgery. So thanks for letting me be here.
Cool, awesome. Tan, since you're on Zoom, do you want to just say hello and we'll just go around the room here?
Sure. Haven't chatted with everyone, but hi, I'm Tan. I'm a undergraduate senior. I'm working with Anna on the Intro to Global Surgery course.
And Anna's, I think, driving. She said she was going to be on Zoom, listening in.
I'm Angel. Nice to meet you. I went to medical school in Mexico, and I've been working here for the past year with Dr. Price, Dr. Rodriguez, and Dr. Brownson in projects in transplant surgery, minimal invasive, and breast surgery. And now I'm going to residency, but it's really nice to meet you all. And thank you.
And Ray Price, general surgeon, previous director of the Center for Global Surgery, and working on several projects in several places.
I'm Leif Sorensen. I'm an undergraduate here at the University of Utah as well. I work closely with Angel with Mongolia and Cambodia specifically in breast cancer, liver transplantation, and minimally invasive surgery.
Great, of course.
Where's your friend that you introduced me to yesterday? You said he was gonna come.
I don't need to, huh?
Text him, get him on the line.
Okay. I have a
Oh,
very
boy.
good friend who's he's
Good
captain
job.
of the swim team, so he's been busy, but he speaks Mongolian and Spanish fluently.
Oh, look at
Yes.
that.
Been wanting to get
And he
involved.
was in our, I spoke about his class yesterday.
Oh, good.
And
Yeah, yeah, yeah.
got a lot of interest.
Yeah, that's great. Part of the challenge is that there are lots of different groups at the U with lots of different interested students at different levels. And one of the many things that's on the list of things to do is how do we organize ourselves to be able to attract those great students from everywhere. I mean, including the global health concentration of the MPH, including the Office of Global Health Education, the medical students there, which, by the way, we did not, Anna and I helped with this medical students to set up a talk today on global orthopedics, and somehow, I guess I did not ask her to actually send that out to everyone. So none of you actually got the announcement for that. So that worked out really well on my part. But we had one of the orthopedic surgeons from the University of Rwanda give a virtual talk on the need for global orthopedics. And she's the only woman orthopedic surgeon in that country of 13 million people. And one of 30 orthopedic surgeons for 13 million people, which is just an incredibly small fraction of the number of people that they need.
Yeah.
But some of our orthopedic surgeons were there last month at a different time than I was there as a part of the School of Medicine group that went there last month to create and invigorate previous partnerships for the School of Medicine. So there's increasing momentum with that particular partner. So I guess we can just kind of give some very specific updates, and maybe I'll kind of talk a little bit about some of the Rwanda stuff, and then we can kind of talk about various other things. And just for Hafsa and Kimberly, the way usually this meeting runs is that we try to have intermittent speakers, either internally or externally, or getting more in-depth input about particular projects, either projects that we're interested in or that we're working on, so that we can kind of really share and brainstorm. And then the other sessions are less formal, like today, we're just going to give updates on different projects and where things are. Dr. Price and I have both been traveling a lot in the last 2 months, and so there's been a lot going on to discuss, and Angel's finishing up, and Leaf hopefully will be joining us soon, which I need to talk to him about. And so there's just a lot of different things that we need to kind of all as a group kind of catch up on. So I guess I'll kind of go first. Several different things happening with work specifically in Rwanda. One, as I mentioned, the institution. There are multiple different people across different departments of the School of Medicine. So pediatrics, OB, orthopedics, internal medicine, and even the College of Nursing. Everyone had various links for one reason or the other over the course of the last 4 or 5 years at the University of Rwanda, and so a couple months ago there was a discussion about, have people gone back, or who's gone back? How do we restart clinical exchange? How do we create educational partnerships? And so a team convened and went last month. I want to say actually it was like February, not March, because now it's April. So in February, and met with the respective department heads and the dean, et cetera, to kind of keep that momentum going. One of the next steps that we're going to be working on is to see how to create there's several memoranda of understanding with several different parts of the university and the different departments and in the Ministry of Health across all of our different departments. And now we're trying to see if we can create something that's broader. So that's not something we will be doing. That's hopefully something that Office of Global Health will be working on. That's one of the key things. The second key thing is how do we formalize the process for residents and fellows to go and participate there, and sorting out the risk management and liability and malpractice, et cetera. And so we're working on convening to discuss that, to see how do we make sure that all of our trainees are appropriately covered, and how do we make sure that they're supervised by the appropriate person. What does that look like? And that looks different from medical students to residents. So that's another thing that we're looking at. And then I was supposed to go this past month. So I've been there twice in the last 2 months. And this past month I was there for my own project, which I'll talk about in a minute. But also the Department of Radiology had a radiology resident who's in the GME Global Health Scholars Program that's run by the Department of Pediatrics by Jeff Robeson. And the radiology department has a small collaboration in Uganda, and there was an Ebola outbreak there last year, about 6 months ago. And so the Department of Radiology was not terribly happy with how things were going there. And so the radiology resident who was going to go there reached out to me and said, can I come with you to Rwanda? So he was in Rwanda for a couple of weeks. And so he's going to be giving a talk back at the Department of Radiology about, again, being a part of this multi-departmental collaboration in Rwanda. And there was a lot of kerfuffle about his malpractice and liability and supervision, and none of which had been worked out ahead of time, although I had been told that everything was all sorted out. So it was great. So we got to handle all those emergencies, acutely, but everything was fine. He was fine. So that's sort of what's happening there. And then in terms of my project, we have this 5-year project for developing emergency systems in the capital city of Kigali. This is now the end of year 2 of this 5-year project. We had to report back to the NIH, which normally they would ask for a report sort of mid-April, and they decided they were going to actually ask for it by the end of March, which was a little curveball that I wasn't expecting. I was like, sure, yes, I can do all of the work and do analysis and write up everything and send it to you while I'm doing it. That sounds great. So, and that's what we did. So we spent 2 weeks working on testing the software that was going to be implemented across the city and figuring out how to test it, then testing it, then figuring out how to train staff, and training them and evaluate them, and giving them a chance to evaluate the software, and then writing all of that up to be able to get our funding for the next 3 years. So that was a very big project and very a lot of time and energy and weekends and late nights. So that was pretty busy, but that's moving in the right direction. Now we're working on the training plan for the next several months to have it go live and be implemented on August 1st, which will be my next trip there, is sort of end of July, beginning of August, to be there and meet with the Ministry of Health and meet with all the digital health folks and be there for the implementation to make sure that there's no major issue when we try to convert the entire EMS system to this new system. So that'll be an
Really
interesting
cool.
project.
Can you
Really stressful.
share? So
And
since we've got students in here who have not granted, so, we're trying to write some grant things. You have a grant, and we say we have a grant and it's funding all this. Can you just share, how does that work? It's an $850,000 grant or something. Does the university get some of that? How do you get paid? How do the people there get paid?
Right. What's the process?
What's the process of how you
So
grant is a bit one word and it's a
Yeah,
big deal.
and it sounds even that description, while that sounds rather straightforward, is more complicated than you can imagine. People have lost millions of dollars in grant funding because that process is not worked out. And I know the people in Rwanda have sent back millions of dollars because they can't get the money in to the right places. So even or getting all of those things lined up is really tricky. I spent 1.5 years trying to get one grant actually into the country. Like, we have money, we just need an account to transfer it to, and have a human on that side who will be responsible for those funds. That infrastructure doesn't exist. We have Kimberly and Hafsa and Xavier, who's not on today, but we have a lot of support for that, and that doesn't exist in most places. It has to be constructed.
It's a huge challenge.
in many places.
Yeah.
So that's the thing. So most grants that are called, like, usually federal grants, and even state grants, have two separate aspects. So one's called an indirect cost, which is basically the cost to the institution. Like, so for every grant that is written from somebody at an institution, the institution has staff who won't necessarily be on the grant, like Kimberly and Hafsa won't necessarily be included in every grant, but they will probably help us with all the finances. Hafsa may help us with actually writing the proposals, things like that. But we won't necessarily, because they're paid for by the department. And so the department and the institution, to recoup the cost of having staff, will charge the funder an X% addition to whatever the grant is. So if the grant's like $100,000, the institution, every institution will have this indirect cost rate, and it varies anywhere from like 45% to like 75%. So Harvard charges 75% for their grants for indirect support.
75%.
So if you put in $100,000 grant, the funder, whoever that is, Gates Foundation, NIH, will be asked for $175,000, $75,000 for the institution, $100,000 for the project. And the $100,000 is called the direct cost, so it's directly to the project team. And then you typically have to budget in that, like, what, who's the PI, who's going to be responsible, how much of their salary will be supported, who else will be on that project, who will be their co-PI or something to that degree if it's in another country, what will be the other research staff, what's the cost for stats, what's the cost for travel, like all of those things will be budgeted. And then not always, but usually, adding in inflation over the course of time as well. And then typically that'll be associated with some degrees of mandatory reporting. That could be quarterly, it could be 6 months, it could be annual, it just depends on the funder. And typically the funding will be contingent on meeting all of those reports. So like that was why it was a big scramble to get this, like we had planned this testing to finish by end of March, and then plan to have 2 more weeks of time to digest it and kind of we look at all the data and make good plans, and then submit a report in mid-April. But if they wanted it by March 31st, then they have to get it by March 31st. Otherwise, we don't get funding on July 1st, and it takes them them time to review all of it.
What does it usually take for the grants here? Like Harvard was $75,000. What is you?
Kimberly, do you remember? I think it's like 35 our indirect cost rate.
Yeah, it was 32, but it may have changed a little bit with this past fiscal year, but it was around 32% previously.
Yeah. And interestingly, so every institution gets to charge that. So like the University of Rwanda can charge an indirect cost rate, but some agencies like the NIH will limit how much it'll allow for that rate for non-US organizations. So it'll say, so NIH has a rule that says it's 8% for non-US institutions. So it doesn't matter how many research finance people you need from your institution, like you get 8% if you're not in the US. So, but that's useful. We had in Rwanda, we actually had to work through what's called a contract research organization, basically an NGO, the sole function of which is to help manage research funding, that Stephen Relisa set up because he had to return $1 million of grants.
Stephen set it up. Great, brilliant.
So who was the former dean who came here multiple years ago. And so that agency manages the financial reporting. So they're registered with the federal government they have their own tax ID numbers, and they have they've done all the registration, because they have to be accountable to the US federal government for any tax dollars that are essentially they're getting. They need to show audit trails and all the stuff, which that agency seems to be able to do. I don't know how well it's not been audited. I'm a little skeptical that they're as good as they paint themselves to be after having worked with them for 5 years. But there's no other choice, because I've tried to go through the university and spent 1.5 years and almost had to return one of the NIH grants. So, so that's how grants typically work. And then the grants themselves can be quite substantial to put together. Like this was probably only 150 pages. But like I've submitted 400-page grants as well. So, and that usually takes, probably each page takes about, I don't know, a couple of days to write. So times, like it takes weeks to write grants of this magnitude, which is why institutions have a lot of support. And if you get, especially NIH grants specifically, the institutional rankings go up. So the institutions are very interested in getting NIH grants and supporting faculty to get NIH grants. And that also means the faculty can get promoted. A lot of their promotion is based on NIH grants. So there's a lot of push towards getting specifically NIH grants.
Now you mentioned you almost have to give back money because you just couldn't get through the university, the process.
Mm-hmm.
Where are we with the process here at the university and making sure that we have ability to do that? We don't have that problem. You had to go to an outside organization
In Rwanda.
in
Not-
Rwanda.
Yeah, not here. We have the processes, but in Rwanda had to go to an outside
Oh,
organization.
Rwanda couldn't do
Yeah, at the University of Rwanda.
it. Got it. Okay.
Yeah, not here. Here, thankfully, we have lots of good support. But it's tricky because even the Department of Surgery, up until this grant, there was not a process to do that from the Department of Surgery. And Kimberly, I think Sarah told me this, like we haven't actually had any international grants with an international partner. So that was like even setting that up properly was not something that was done. And then the
Setting
actual
up
transfers, all of that.
Yeah, the transfer of money and things like through Ghana and through Edward and things like that was all
Yeah.
charting new pathway. And
Yeah.
so I'm excited that we've got people here that can really create those pathways that can be ingrained, because it's not been something the university has been
Yeah.
good at.
And that's also a good reason for us to focus on the places where we have those set up.
Right.
It's a little bit of a trap, right? Because you've gone through the work of setting up those processes. And so then, you don't have to be focused on that, but you then have all infrastructure already set up. So it makes more sense to focus on that.
It's kind of like using a robot over and over to make it cost effective.
Yes, exactly. Exactly. So that's why even our work focusing on Mongolia, Ghana, Rwanda makes a lot of sense, and not have lots of other like research that requires a lot of research finance support at other sites. But like the contracts, and so like the Cambodia work is a contract, which is great in some ways because it is more direct to the funder as opposed to through the university process, which is what's going to which is uncharted. That's the uncharted, because reimbursements are a whole lot easier than creating that research finance process. So
How would a donation work to the center instead of a grant? If a private party came to you and said, we want to give you $1 million.
So you, first of all, that's actually relatively easy. They can write the check. The department will tax it.
Okay,
I think there's like say 8% tax or something like that from the department. But we just have to create an account and put it in, and then you can use it as much as you want. But that's money coming in, not money going out.
right.
The process is is very different. And especially because it's not federal tax dollars,
Mhm.
because the federal government ultimately has to be accountable
Right.
for how that money is spent. So
Interesting.
the rules for that are a lot more stringent, understandably.
Right. Interesting that the university still has a tax on it, though. I guess just that.
Again, all the
Gotta pay
support
for all
stuff,
the
right?
support
'Cause you
stuff.
need somebody who's managing the accounts.
Right.
So,
So you also, now you met with ACS over there too, right?
so yeah, so I haven't
Yes,
even,
that-
this is like only, this is only a part of my report from the last, like 30% of the last 7 that I've spent in Rwanda. So yeah, so that's my project. And actually, one of the reasons I was there last month is that with another colleague, we just got this big grant from the UK that is finally underway, which builds on my project to basically take this software and add to it information from hospitals across the city, and then expand it out to the rural part of the country and try to see if you can use the same software and modify it for use across the rural part, which may not work the same because infrastructure, being able to figure out where patients are, figure out what the EMS services are, where ambulances are, all those things are going to be completely different in the rural setting. That's another 5-year grant, and that launched last month. There are more meetings for it next month in Kigali, which I won't be at because my family will kill me if I spend any more time not here. But that's so that is just starting. So that's another 5-year grant. So like this is just sort of stacking on each other. So that's what's happening with that. And that along with that is the trauma registry, which we've worked on supporting to try to see if we can get baseline injury surveillance data. So that when you make an intervention, like we're going to improve pre-hospital care, then we can actually evaluate if it's working. Because you can create a beautiful software. It may work really well. People may like using it. They may actually regularly use it. But if it doesn't actually make any clinical difference, or if it actually makes the situation worse, then that's a problem. And unless you evaluate it, you don't know if it's actually going to help or hurt or not, and not do anything at all. So that's a big process of what we're working on. And to do that, you need things like trauma registries. You need various data collection systems to quantify the impact. So that's another thing that's going on. We're actually in the process of finishing a paper. Sarah Schoenholz and a couple of other people are working on finishing a paper on the trauma registry. It's the first comprehensive trauma registry analysis for the country of Rwanda. And that has taken like a year to work on. And another project that finished that we're going to need to work on writing up is a trauma quality improvement program that we did as a hybrid last March through December. And then our main collaborator sent a report just a few weeks ago about the sort of results of that. And we're hoping to write that up as a pilot. How to conduct how to create the curriculum, because there's not great QI curriculum for low and middle income countries. How we implemented it, what the challenges were, what the outputs were. Because of that program, they now have identified a number of different projects to work on. They've also planned to start newly a morbidity and mortality conference to actually evaluate the care. So there's some good short-term and long-term things that are coming out of that. And then our burn team is interested in working with them. So we're trying to make that connection so that they can help with some of the burn projects that have been identified. So there's lots of good momentum there. And then lastly, the American College of Surgeons had been asked by the Ministry of Health to help with training related to trauma care and trauma systems, cardiothoracic surgery, vascular surgery, and plastic surgery. And so this last week, there was a group, including the very top of the American College of Surgeons, Dr. Turner, and then several other folks who were there kind of to meet about what the American College of Surgeons can do for the Ministry of Health. A lot of politics. I don't know exactly what will come of that. And I'm trying not to be too skeptical But we'll see if anything will come of that, because there was a lot of talking and not enough listening, and some mismatch of priorities and interests, and so we'll have to see how that goes. But there were quite a few different meetings with the head of trauma, so that the committee on trauma at the ACS is what verifies all the trauma centers across the US. And one of the asks from the Ministry of Health had been, can you accredit our institutions, which they can't. They're an American organization. They accredit American hospitals, because hospitals all around the world have different standards, capacities, capabilities. And so, like, who are they to say what the accreditation rules should be? In part, that was part of the discussion of, we can help you create your own rules, and then you can update those rules as time goes by and decide use that as a roadmap. So that was some of the discussion, which makes sense, right? Like, every country is going to have its own needs, have its own demographics. Some places have, pediatric surgical capacity, some don't, and so that's a big thing. Burn capacity is different things. So there's a lot of variety of different things that need to be addressed.
They've implemented in some of the South American countries, but developed one for South America.
Yeah, and there was some discussion of sharing some of those, and so there's we'll have to see what comes from that, and the team was there for about 3 days, and I kind of inserted myself into their trip, but they had not spoken really to me or to any of the other 4 American trauma surgeons who've been involved in Rwanda for the last decade. So it was perhaps not the most savvy way of thinking about it, but more power to them. So we will let them figure out how it works. And then they also didn't know that the main team that had invited them had been disbanded by the Minister of Health, like literally the day before they arrived. And I don't know when or if they've found that out yet. So there's some major issues.
Politics are great.
Major issues. I actually don't know if they've even found that out yet. But so yeah, so lots of interesting things happening there. I have various PowerPoint talks I'll give again in a few weeks or months when there's a lull in the chaos. I'll update you on how this project is going.
Fantastic.
Yeah.
A lot of work.
Yeah, all kinds of madness. So
We can give we do the update now with the stuff. Actually, maybe what we can do is I can mind and give a brief intro to it.
Do you want to show the PowerPoint you
Yeah.
showed this morning?
Yeah, then you bring up your, okay. Passcode. So here.
With that, one friend I was telling Dr. Price about, his dad was a PA for the embassies his whole life.
Mhm.
And so he's grown up in South America, Russia, China. And so when it comes to global minded people, he's lived pretty much everywhere, Middle East, Jordan.
Utah Global.
that's great.
He's an
First
engineer
you,
as well, which is just different because he wants to go to medical school, but he's kind of interested more in medical innovation.
Yeah.
And I was explaining that we have a big side of that I don't fully know because I'm not engineering based.
Yeah, you should send him the master's track information,
Yeah, definitely.
because I mentioned PhD in biomedical, and constantly we're connecting. We're both constantly connected with the biomedical engineering department.
Right.
So
Yeah.
So. There we go. So 2 years ago this summer, we were contacted and asked what it would take to get laparoscopy in some places in Cambodia. We had people who had seen what we'd done up in Mongolia, and it eventually led to getting proposals and project. And this is the people that reached out to us were from the humanitarian component of the Church of Jesus Christ of Latter-day Saints. And we learned that they have a big mandate to improve healthcare throughout Cambodia. So we gave them a proposal. They asked actually for the area president in Hong Kong asked for a 10-year proposal. And we said, well, how about a 3-year proposal? Let's see if we can get it to work first in Cambodia. There's no guarantee that our model that we've done in Mongolia would work necessarily in other countries. So we gave a proposal of doing a site visit in Cambodia. We did in February of last year. We visited the main teaching hospital in Calmet in Phnom Penh, and a place up in the northeast called Kampong Cham. We actually saw several other sites that really weren't good ones, but these two were good. Calmet's request was to set up a laparoscopic skills training facility and to do advanced laparoscopy. We weren't sure where their skills were, so we thought we could maybe develop the skills training first. Kampong Cham, they've never done a lap chole before. Can we start laparoscopy there like we did up in Mongolia at several sites? The plan was to come back in October to both sites because MOUs weren't quite completed. We pushed off to November. In November, the MOUs were complete, but the equipment could not be guaranteed to be on the ground in time. So that was pushed off to December. And then it was split up because Kampong Cham couldn't do things till February. And so we have one trip that went in December and one in February. The one in December was at Calmet Teaching Hospital, and the one in February was at Kampong Cham. So that we are still back here in October. We're supposed to be doing a second site here, or second visit here by February, March. This has been moved to September. But the plan is over the next couple of years, each year to have new sites. We've done already more site visits and have a plan for the upcoming year, which would be to do advanced laparoscopy in Calmet, and start laparoscopy in a new place called Kampong Cham, which is not listed here because it wasn't on our radar at the time. So that was kind of a general overview of what we were going to do, just so you know the area. Here is Phnom Penh. Here's Kampong Cham. It's about a 2.5-hour drive. We're going to go to this next year is Kampong Cham. Other sites we've done site visits we plan on going to is Battambang, another place out over here. This is December of this last year, where we set up a laparoscopic skills training course at Calmet Hospital. The humanitarian services purchased, as we worked with them, these laparoscopic training boxes. We have 10 of them in this facility now. And we taught a 2-day course teaching the faculty how to teach the residents, and then had 2 days where the faculty taught the residents. And so it really was setting up a skills training facility. We had lectures, we had videos, we had hands-on skills training. A lot of credit to actually Ann Hill and to Leaf here, who helped really put a lot of that together, as well as Anna and several others putting the content together for that course. And what we did is we also tested them. We'll have Ann Hill share that with you. We want to figure out how to teach them how to evaluate the courses that they do, how do they evaluate the residents, and we'll show a little bit of that. Up in Kampong Cham in February, we then went with a team. This team is made up of a couple surgeons, a nurse, biotech, researcher, anesthesiologist. So we teach the entire team how to do laparoscopy. And we start with lectures with really everybody who's interested in the hospital, doctors, nurses. We'll take janitors, we'll take anybody, so they learn about laparoscopy. We do a hands-on with the instruments during part of that course. But then they do really very specific hands-on training in the operating room with the operating room staff, with our nurse and our biotech. Just so you know, this is FEMU's executive director's husband. This is Phil Padgett. So there's a connection. Our new executive, or the
And chairs.
he moves the office right next to his Paget. That's his
Oh,
wife.
his executive assistant.
Assistant, that's what executive assistant, yeah, is his wife.
Okay.
So we have connections there. We also work with them. The foundation able to provide the training boxes at the facility as well. One of them where we could work with the surgeons specifically on these. And what's interesting here is bringing the surgeons from CalMet to teach with us and connecting them so they have mentorship even after we're gone. This is Dr. Vutia, who's part of our research team from CalMet Hospital. And then the anesthesia, and these patients' pictures were done with their permission and told that how we would use them. And this is our anesthesiologist working with their anesthesiologists and our surgical team as we do pre and post-operative training. And then the intraoperative skills is where we gradually give them graduated experience over a 2-week time period, doing 3 gallbladders a day, with training in the operating room, outside the operating room, anywhere we can train, with the goal of having them do it by themselves before we leave. I think this was a fun statement by Dr. Poe. Watching is easy, doing is another story. But they were actually able to do really pretty well because we have received today the videos and pictures of their 8th laparoscopic cholecystectomy by themselves since we left. This is, we did some training on cholangiography, both at CalMet and at this hospital. Down at CalMet, this was a patient that had normal LFTs, supposedly a normal ultrasound, normal common bile duct on ultrasound, but the cholangiogram found, after doing an open surgery, 50 gallstones within the common bile duct. That picture there of the cholangiogram. So this is Angel working on the data collection for the previous year of all the open choles and appendectomies and getting a baseline as we work on trying to do quality analysis of going forward. And I show this to you where we're planning to go in the future. This is Kampong Tom, which is the one that's up here, halfway up to Siem Reap. It's about another 2.5, 3 hours from Kampong Cham. And this was in the Desert News about 3 weeks ago. The humanitarian organization has a $1.5 million project separate from ours, building 2 new operating rooms, expanding the OB area by double, remodeling the ophthalmology building. There are 38 buildings they're working on remodeling in this area. In the middle here is Vitia, who is one of the main surgeons from CalMet. But initially, when we started this a year ago, said, why would you go up there? Those are just country doctors. I don't think this is worthwhile. He is now fired up and sees the vision and it wants to be engaged with this. It's been pretty exciting to see that transition. So, Angel, you want to just show a little bit of the data that we. Parker, nice to see you.
Good to see you. Thanks for letting me join.
Parker is
He's my friend that I was telling you about.
This is some of the data that we collected from the trip from December.
Fantastic.
This is data on the skills training that the doctors did. And what we evaluated last time consumed performing each skill. And also we had scores and they were evaluated with a rubric. So everything was standardized for all the participants. And we measured the time that it took them for each skill based on the times that, well, those times are actually based on our times and also FLS based. So it's a little bit different from FLS, but it's on the same range. So we measured their times at their first attempt with each skill and their times in the last attempt after practicing. And we saw that there were improvements in both time and scores because the scores took into account the precision meaning that they dropped less objects, or they also takes into account the time, or they did not break the rubber band. So they, as they practice, they became more precise with their skills and also faster. And we have the same kind of data for all the different skills that we did: rubber transfer, circle cut, and also we have the different participants. We had surgeons, OBGYNs, residents, and the average. Most of them were surgeons, followed by most of them were surgeons, followed by residents in surgery and OBGYNs. And one of the interesting things that we saw is that actually surgeons improved the least in, for example, in rubber band transfer, but actually they were the ones that had the least room for improvement, because they started out being faster in certain skills. So we saw these kind of things across different skills. And the other thing, so we have this for all of the different skills that we have. And the other thing that we have is that after this course, we made a post-course evaluation survey, where one of the things that we wanted to show is that how does this translate for, clinically, which is one of the difficult questions. But the thing that we started by assessing was, just 1 second, let me see. Can you see that screen now? Or no, I think I have to stop sharing.
I just stop sharing first and bring it up.
So we did this survey after the course, and actually we did the survey during our last visit to Cambodia, so in February.
It's not coming up on my screen.
Can you see this graphs right now? Everyone online?
No, I
No?
can't.
Okay. Let me see. Can you see them now?
Yes.
Okay. So here again, we asked them how were they feeling before, how comfortable they felt with every skill before the course, and they were kind of comfortable and more on the side of not very comfortable for some of the skills, and this was evaluated with a Likert scale. And then we asked them questions about how would they rate each module and what do they think about each module, how it could be improved. We had even a feedback section for asking them for feedback for every module and general comments. But then we asked them how many times did they practice after the course, what was the reason why they were not practicing, if they were not practicing. And then we asked them their own perception on performance and how long were they practicing. But this is one of the most interesting findings, I think, is that they reported feeling more confident in the OR after the course.
You mean for like an open case or for a lab case?
For surgery,
Laparoscopy.
after laparoscopy. Yeah, laparoscopic. So we just said OR, not specifically laparoscopic surgery. Yeah. So, for example, I think I have more knowledge about laparoscopic surgery. Here we did specify laparoscopic surgery after the laparoscopic box. And then we asked if they felt that they have improved dexterity and precision during laparoscopic surgery after the the training, and also they reported feeling less stressed in surgery after taking this course. The people answering this survey were again mostly surgeons and residents.
Do you have a sense of their volume beforehand?
I have the
or
volume
after?
of Kampong-Cham, but this data is from CalMet.
No, I mean, of these individuals who are responding, like how many cases do they do before this training and how many cases?
We have
do
an
they do
idea
after?
of the time that they were practicing before, in time of being surgeons or
Sure.
practicing surgery, but we do not have an idea of the volume of cases.
Yeah.
So we have a sense of time, not number of cases.
Okay.
And then this is again a program development section where we ask for feedback from the attendings. And then we ask the attendings, only the attendings, if they had worked with the residents previously prior to the course. And then we moved on to a part where we were only doing the survey for the attendings, and we asked their perception of the residents. And they also reported that residents seem more confident in the OR after the laparoscopic box training, that they have improved knowledge and dexterity and precision, and that they seem less stressed during laparoscopic during surgery after the box training. So
Great.
this is one first step in moving forward to showing the clinical translation of the training box to like how does this impact the residents' performance and the surgeon's performance in real
We struggle
scenarios.
with how do you evaluate the education program? You know, it's a
Yeah.
little easier to, when you start laparoscopy in place and we can look at post-op complications and things. But how do you, we struggled this with SAGES with our courses we did all over Mexico. What are the metrics you use to see if your educational program is actually worthwhile? You can come up with pre and post course surveys, we can do, little
Right.
things. But really, how do you evaluate that? We're still struggling with that.
I mean, we don't know that. We don't know the answer to that here in the US for
No.
our trainees.
And so, but I think this one is a survey. This came up with a spontaneous comment from the surgeons there as before we developed our survey was, gosh, you know what? We're noticing this in our residents in the operating room. And we thought, well, let's see what everybody thought. Let's see if that's really
Yeah.
something that, and the residents said, we have never had a 2-day course
Mhm.
of anything.
Yeah.
This
Yeah.
was totally new, totally different. And they just soaked it up. So this was just a phenomenal opportunity.
A part of me wonders if there's an opportunity to tie into what Yihan Lin was working on and the surgical trainer that she had set up.
Mhm.
That she presented about several months ago, the little fishing tackle box with all the different bits and pieces. And if there is enough appetite to have a general surgical, basic surgical skills kind of training, and where they have some, if maybe there's a curriculum where it's like, year one, they have that sort of general, they have some degree of like 1 day of general training, 1 or 2 days, whatever. And then they have that box to be able to practice technically. And then year 2 is laparoscopic, and there's the laparoscopic trainer. And so that may be more formalization of their residency.
Training, yeah, that's,
Just throwing it out there.
that'd be fine. Well, that's, as we're now trying to look at, go ahead and talk about the grant.
So there's this grant that Dr. Price shared the link with me, and I went through it, and I think we can submit this project for this grant because it's looking for training approaches for healthcare workers. And it mostly asks that the training is available online and on open source. So that's one of the things that we have. I already started a draft for this grant, answering to the questions that they ask. I can show that in a minute. But the other thing that we have is the Thinkific course. all of the skills and the
Basic content.
basic content that we developed for Cambodia is already uploaded here. So and it has audio and videos, and so that participants can go here and watch the videos again and train by themselves, and hopefully start self-sufficient training with this. For example, let me show you this.
One of the questions came up, Suda, and we had to find out who to contact. This grant says to develop this to be an open source. With IP at the university, we thought to do this grant, we ought to get somebody on front, even with the colorectal, if they're going to do it, to get either whoever's in charge of IP or the lawyers on board for going for a grant like this, where we're going to make it open source.
Well, so you'll definitely have to submit this through the Office of Sponsored Programs.
Mhm.
So that means that you'll have to submit it at least like 10 days before it's actually due for all of our appropriate people to look through. And they may ask for additional language to go into the submission about that. And it may require, yeah.
I wonder if there's someone to talk to ahead of time that we figure out the kind of language to address that issue. I was trying to
Yeah,
think
Kimberly,
who,
do you have any suggestions on that? I think part of it is I don't know if Isabella is necessarily the best person, or just somebody at OGC.
Yeah, I can ask Isabella and see if she knows if there's a person that's not her that would be a good person to ask. Isabella can answer almost any question that you throw at her, I feel like, but I can reach out to her and see if there's.
If she's the right person, that's fine too. But I just it seemed like she was sort of further down in the sort of approver.
Yeah, I can reach out to her just to see, because you're just wanting to make sure that if there is specific language that the university needs, that it's included instead of having to go back and rewrite it, essentially.
yeah, well, the university is very protective of their IP stuff. And to say we're going for a grant that's saying we're going to make this product, but make it open source.
I think as long as that's written and the university has had a chance to review that,
Yeah.
that should be okay. But you can certainly explore. I think Kimberly could probably.
Yeah, Kimberly, if you have anybody to kind of talk to about that, and as we,
What
I
is
mean,
the-
we hate to get this all together and say, sorry, you can't go for that grant because you're making it
No,
open
they're not.
source.
They're not gonna. No, they're not gonna say that. What does the actual grant proposal look like?
One second.
Bring the grant, the request thing.
Yes. You mean the draft or the application, the proposal,
Application and like,
Like the requirements for
Yeah.
the.
the requirements.
because it might be useful to send the requirements to Kimberly so that she can
Yeah, let's do that.
send it to the OSB folks and see what they recommend while you're working on it.
Right.
Because for the software, so for the NIH requires basically for anything that they fund to be freely available. Like, so we had to put in all kinds of language developing this software for Rwanda.
Really? I
And
was going to ask you about that.
had to create all kinds of MOUs. It took like, I mean, there were 14 versions of one MOU, if I recall correctly. I think I lost at least a decade of my life expectancy.
And why did we do this?
I know, because we're stupid, that's why.
So they're offering $75,000
Uh-huh.
for these projects, and I think this could be used for all of the projects in minimal invasive surgery
Yeah,
in Ghana, Cambodia.
yeah,
One of the requirements is that the PI is from and or based in a low and middle income country.
Here's the total cost, the indirect versus direct cost part.
Yeah.
We talked about earlier.
And that's kind of the part where I already started the draft, but I have limited experience with these kind of things.
Yeah.
So there are a couple of questions that I need some help for answering in the draft. And also with the budget, I think
Yeah.
that.
Yeah.
that's
Hafsa, this might be a good thing for you to help us with. We can talk about this tomorrow when we're scheduled to meet as well. See how to put some of this stuff together. So obviously you don't know the content necessarily, but there may be specific sections that you can help us put together and see how that goes.
The draft here.
Yeah. So I think that we should probably work on that.
Anyway, that's a little update of where we are with that. We do have, as I mentioned, we'll be in Ethiopia doing a week long there. Sabrice is coming over.
Great, when
Phil
are you going?
Paget. So I have to give a talk at the Kenyan Surgical Association and this international meeting. And we figure we'd go up after that for the week in Ethiopia rather than coming back.
Yeah, that makes sense.
And
When
bring
is
people.
that?
So we're doing that Ethiopia is the first week of May. The Kenya is,
Oh, that's right. Okay, and then you'll
Yeah.
be back for when Edward's here.
right, yeah.
Well, it's already 4:00.
Yeah.
And I have to go get my, son home so I can come back, be on call overnight. So, yeah, no, this is great. It's a great opportunity. And the other thing it might be worthwhile is to see if we can contact the people at Intuitive
Okay.
and discuss it with them.
Okay.
That's often a really critical move with any funder.
And it was very nice to meet the president of the foundation at West African College of Surgeons. She
Yeah.
was going to be at Sages,
She
but
was
then
at
she got
COSEXA.
COVID.
I think she was at
She was at
COSEXA
COSEXA.
because I remember her. Yeah.
Yeah, so I've got her contact and.
Yeah.
uh,
Yeah, so I think it would be useful to discuss
Yeah.
this with her.
So, especially a couple of questions that we have, we can give
Yeah.
her a call and see. Okay,
A quick question for you. I ran into Michael Good. He was,
Yes.
yeah, the director, and I mentioned the Center for Global Surgery and kind of invited him informally to come stop by and maybe speak or talk. And-
Michael Good, our dean?
Yeah, the dean.
Okay,
And so I was just following up with you with that, if you
Yeah.
thought that was appropriate, maybe even saying for works in progress or finding just a
okay,
way to get him more involved so that he's more aware of the projects and possibly the things that come from
good for him, hear from the students.
yeah,
getting him.
yeah, yeah.
They hear the
Yeah.
students are interested and engaged.
Yeah, that's
Right.
great.
Does that seem, what are your thoughts on?
Yeah, I think we should discuss that.
Okay.
Because
he was very interested and he knew everything. So of course,
I
I know Dr. Dryman and the program that you do. I said,
Yeah.
Oh, we'd love for you to stop by and learn more about kind of the projects we're in. And he said,
Yeah.
yeah, I might need to do that.
Yeah, yeah. I think the best way to do something like that is to have a day. We could consider doing this at the end of this year, and this is one of the things I'd like to get to, is annually have a little presentations. Maybe it's an hour, maybe it's 2 hours, but everyone who's worked on different presentations give a little 5-minute talk
Right.
of each presentation or each project, and then invite people like Mike Good or our new chair or various folks to participate. And that's also a good opportunity for us to invite people from across the university, from the other students who might be interested in participating, from the other programs, Hinckley or wherever,
Right.
to see
Absolutely.
who wants to join. And if you can, if we do it in like May, June,
Mhm.
and then that way people also start thinking about how to participate in any of these projects to pick it up. So
I think there's an invitation from the Harvard program in this month, I think. But it's kind of a meeting like that. I wonder if
Yeah.
we could also invite other programs for.
Yeah, absolutely.
yeah, I think that we just have to kind of, I would say we'd start with just an internal one.
Right.
Because we probably need to do it, spend some time talking about
Right.
in our environment,
Right,
before we necessarily invite a lot of other folks.
right.
But yeah, I think that's I've discussed something along those lines with people from other institutions
Mhm.
to see if we can have a rotating thing.
Right.
So like a works in progress that's virtual that
Mhm.
rotates like on a monthly basis
Mhm.
across different institutions. So there are lots of ideas. It's just a
Right.
matter of actually
Sure.
executing.
Good to see everybody online.
Thanks for joining us.
Good day.
I'll see you.
Go to sleep in Pakistan.
Thanks.
Okay.
Thanks. Bye.
Yeah.
Bye.